waiting. So we are expecting Diane and share her experience in relation to her son, but as she's not yet here, I wondered whether we might just do a little bit of the early stages and approve our minutes and so on to move things forward so we don't fall behind on time. So what I'm going to do in the very first instance is say welcome to Nick, Nick Kane has joined us at her first meeting with us. I really sympathise with you because I came on my sort of day 3, we had a board meeting. It's a little bit in at the weekend, but actually you get all of it in one go, which is not a bad thing. So Nick has joined us as our chairman, and you are very welcome. And I would also like to say welcome to Kerry, who's joining and will provide a lot of support, I am sure, in terms of detail and answering tricky questions. So you're welcome. And then we have Jamal and I think other team members here to observe and support in terms of our patient experience, care experience. We do also have some apologies for absence. Mark is not with us today, and Hilary Thomas, so a couple of our non-exec directors are not with us today. Perfect. I am. When I say welcome, I'm Sarah Betterley, I'm the Trust Chair. Thank you very much. You're perfect timing. We were about to do a little bit of the admin stuff, but if you're happy, we might move straight into hearing from you, if that's okay. Thank you for coming and joining us and sharing your experience and Christopher's experience. I'm not going to make everyone introduce themselves to you, but what you have around the table here is the full board, a mix of executives and non-executives. And we will love to hear from you, your experience. There are some colleagues who I think you will recognise, you might know previously who are alongside with you today. But if you're happy to share your experience, and then if there's time and you're willing, we might ask a few questions. And if we do, we'll let you know who we are as we ask a question, if that's okay. So thank you. I hand over to you.
My son was having bowel problems with rectal bleeding and constipation. He'd actually ended up at one point being impacted and I had to go and have an enema. And obviously, because he's autistic, it's like living a nightmare. Eventually, I managed to get the doctor to refer him to the hospital. And at that point, when we got the appointment time, I phoned the security team. I spoke to a gentleman, I think. Anyway, I then spoke to a lady, Vicky, and she came along to the first appointment with me. I had written down about Christopher for the doctor to read, but luckily, because Vicky was there, where I was getting upset, Vicky was there. She was supporting me. Then she went out, and when the doctor was talking about it, and when I said yes, he will let you examine him, Vicky came with us, and Christopher let the doctor examine him. I wouldn't have had the courage to do that had I not had somebody that understood and was supporting my son to go that far. I'd have probably gone home and cried, and the problem wouldn't have been solved. Vicky then spoke to the doctor, and he agreed that she could go in the procedure with Christopher for the colonoscopy. So, and when we came and sat outside, and I was obviously upset because it's very traumatic, I noticed that Christopher was responding to Vicky. He knew her name was Vicky and he signed to her. And he immediately felt comfortable, and through the whole procedure, the whole appointment, he knew who she was. He knew who he was going to see. And then after that, it was a case of waiting for the actual appointment. During that time, Vicky sent a video of the procedure, the bit before, the middle bit, and then the last final bit, because obviously there's the bowel prep, which obviously obviously I got him to sit and watch that, and he did watch it. I can't say he enjoyed it any more than I enjoyed it, but I think it was broken down into such small steps, and it was very visual, that he was able to understand what was going to happen next. Then we had to come to the appointment where, oh, can I just go back? For the first appointment, Vicky had gone in and she told the staff on the desk that we were coming, so they were ready for us, and we had a separate area to wait before we were called in. Sorry, I forgot about that. And then there was an appointment to see the team that were arranging for the bowel prep. And Vicky had spoken to them and explained to them how Christopher would present and the things that would possibly worry Christopher. They sat down, they spoke to him, they explained to him that he couldn't have fruit, they explained to him what was going to happen, and he understood that, and he accepted that. Now, Vicky had done all that, and we didn't have to wait to go in. We got to the appointment, we went straight in. And then Christopher cooperated with all that. And then that team then rang me the following day. The appointment was meant to be 2:30, and the team then rang me to say that they had brought the appointment forward to 2:00, so we didn't have to wait in the waiting room. And when we got to the waiting room, the staff knew, Vicky Mentis there, the staff knew we were coming. They took us straight into a room and they allowed us to stay in that room the whole time. So that I didn't, so he waited in that room with me, and the one thing that happened then, like Vicky was there and she was talking him through it and that, and then the doctor, what was his name again? What was his name? Mr. Bagava came in, and you couldn't make it up. He went up to Christopher, he signed to Christopher. He signed hello to Christopher. He said to him, I know you're here because of so and so and so and so. And Christopher went, yes. Christopher went to touch his hand. Now that's trust with somebody with autism. And then he said, which I just couldn't believe it. He said, when I see you in theatre, Christopher, I will be wearing green. I won't be dressed like this. So he had thought every step of the way how to approach Christopher. And when he went for the procedure, he was absolutely fine. In fact, during the procedure, I think he told him to shut up. But and then he came back, and then but every step of the way, you couldn't have got anything better for somebody with severe autism. Every step of the way, we were supported. And I just want to, I hope that, by coming here and telling this story, that people will know more about this team, because it will save a lot of problems, suffering for people and their families. And the right thing to do for the staff, because when you've got a team member that goes in and says, this might happen, that might happen, can you be prepared for it? And you've got somebody who speaks, because the thing is with people with autism, with dementia, the tone of people's voices is perhaps one thing that anybody can do to keep people calm. So, and I'm just really grateful that I didn't have, that I had that support, because otherwise I don't know what we'd have done. We'd have been stuck in waiting rooms, and that would have been awful for him.
And possibly have visits, competitive visits where you have to go and try again, take so much longer to get.
Yeah. But it was because of that team and that doctor.
Yeah, that's really wonderful to hear. Thank you. Can I ask how Christopher is? Was the procedure?
Yeah, they found out that he had internal piles, and so but we just
suitable.
Yeah, we decided not. I spoke to the consultant and I decided no. I didn't think he would cope with further surgery, so we just manage it with diet. Yeah.
But you're also reassured that there's nothing.
Yeah, exactly.
About.
Yes.
And it's something you can.
Yeah.
That's amazing. But thank you. And really such a positive story and so important, and really highlights how easy it is to get it right, but so easily overlooked, isn't it? Sorry, were you part of the team?
Yeah. So I'm one of the new senior LD team. Thank you for sharing that. That's really, really lovely to hear. And I joined in January, and to me, like, that's just second nature to do all of that. So it's yeah, we're still trying to get to grips with promoting for the teams to sort of do that themselves without us having to go. We're trying to improve our training and just be more accessible so people can reach us easier. We're doing a lot of work with different departments to see how we can intervene a lot earlier.
Yeah.
So maybe when you get the initial referral to the hospital, we can give you a ring and say, how can we help? Not everybody needs all of the reasonable adjustments that we offer. So we always make it patient-centered and we'll say, you know, this is what we can do, what would you like? And then that's just our everyday job. We just go and make sure that patients are having a nice treatment experience. Yeah, thank you for sharing.
I mean, I don't know whether it would be useful to have like something in doctor's service so that people can sit in their wait for their appointment and see this is something they can ring you
Yeah.
rather than finding out maybe further down the line or not finding out at all.
So at the moment, we're working with community teams to see if we can sort of do information sharing so they can refer people to us before they come in.
Yeah.
So you could give us a ring and say, I'm coming in for a scan. It's my first instance talking to you, rather than getting here, having a negative experience and then being referred to us, which is what we see a lot of. So we're trying to push for people to know that we exist before you get here, for us to be quite accessible through the internet. So you can easily email us or call us. And then,
I'm wondering, as a team, do you ever get notified that we have someone coming into the hospital who might benefit from that support, where we can proactively reach out? Fiona might be able to answer that.
I'd love to answer that if I may. So about 2.5 years ago, we used a flag on our system, which essentially identifies any patient within our hospital that is waiting for something that has a learning difficulty. It's a sort of generic flag. It just means that we've put a tag on that name of that patient so that we can keep an extra eye on it. So what we do now is we proactively trawl the waiting list, both for any diagnostics and any planned care. We trawl that on a weekly basis. We can download on a daily basis a list of patients that have a flag for a learning difficulty and share that, and your team reviews that and reaches out to whatever specialty it is. So it's taken a while, as you said, to move away from the learning disability team telling the specialty that the patients are there to the specialty owning their waiting list and reaching out for specialist support and help, particularly around planning with families to make sure that visits are organised well, the right level of support is in place, and that everything that can be done to make it a successful visit and intervention it can be. So it's really nice to hear that this is happening in a proactive way. And yes, there's lots and lots of information available to us on a routine basis to do.
And that video that Diane mentioned, was that a video specifically for patients with learning disabilities, or would it be a video that anyone who was coming in for the procedure?
It was for learning disabilities.
yeah, so I think we have access to, we're still trying to put together something that covers all the different surgical areas, but there is a resource online that has access to videos. And I'm sure we can use one from there. But just off the back of what Fiona mentioned, we are actively, both senior nurses, so myself and my colleague, are going through the PTL, the waiting list, weekly, and we're trying to move people that have, a wait of 30 plus weeks, trying to expedite getting them seen. But in terms of people coming into the hospital, so we do get referrals from maybe social care or community teams who know that we exist. So they'll say, just an FYI, so-and-so is coming to A&E, they don't work. And that's one good way, but we're trying to get more people to reach out to us. For like this morning, I supported a mum who's also needed a blood test and she needed a distraction. So I used to be a case specialist for a long time ago. So I just went to the case and got some stuff out of paediatrics and took it along with me. So it wasn't that she required a lot of support, it's just that small little intervention. And actually, she managed to get a blood test after 4 attempts. So it's a really small intervention. So we promote for anyone to reach out, and if we can offer the help, we physically go. And if we physically can't go, we'll arrange with the ward for all of the reasonable adjustments to be in place before the patient gets there.
That's to invite to hand up anyway. Introduce yourself.
I'm Ruth Foley, I'm a local GP. So things that are going on in the community that hopefully give you some hope that this is going forward, because I think it's really important that absolutely primary care are aware of such a great service. And I think it's been lacking, truthfully, in primary care, and I think in places it's still lacking. So we're trying to do a bit of a spotlight on it. And one of the teams that we've got, which is quite new in primary care over the last couple of years, is our social prescribers. So they're in place for kind of almost non-medical things, which includes this kind of support. And so my surgery, in fact, my primary care network, which is a group of 5 surgeries, we've approached all of our patients who have got a diagnosis of autism or learning difficulties or learning disabilities. And we've offered to fill with them the hospital passport, which is also used here. Some of them we filled it in with them, but actually a lot of them have wanted to do it away, but a lot of it was around the awareness of this is in place. And I think that's the biggest thing. We don't have to handhold people through that. Actually, it's just letting somebody know this is available for you and to make life better for you. Not just the patient, it's you as a whole family, isn't it? You're a unit. So I think it's a big piece of work because we've got a big part of our community that have really wide range of needs, from really severe autism to autism that might be well masked day to day, but then you come into this type of environment and it becomes completely unmasked. But they still need to have that support. So I think the awareness is coming. I think it's going to take time, I think, truthfully, to trickle through. But I can't praise the team here enough. I think they're fabulous, and I'm so pleased you had such a good experience.
It was.
Thank you. And I think what's really helpful is the way you highlighted how much it helped you as well.
Yeah, because
it's particularly challenging as a carer, a family member, to see someone in distress and to bear all of that responsibility yourself. Having that support makes such a difference.
And to be sitting in a waiting room when somebody's getting distressed and people around you staring. But when you've got a nurse by the side of you, people don't stare because they accept and acknowledge that there's a problem.
Yes. It just encourages that general compassion,
Yes.
which we all need, don't we?
Sorry, Caroline. I'm Caroline. I'm one of the associate NEDs here. My daughter's autistic, got a range of other needs and things. And, you know, I absolutely recognise the effect that it has as a family member, how you're treated, and also the recovery afterwards. A negative experience will remain with your child, and then you have months and years of dealing with that. But I think the thing that really strikes me, and it's been lovely to follow this journey, because I remember Gary Etheridge coming to talk about this work right at the start, was all the positive stuff here and communication actually benefits a much wider group of people. I mean, imagine if you're a nervous patient and your doctor, you know, your surgeon is saying to you, I'm going to be wearing green. You've actually never had an operation. Those kind of things, they benefit everybody. And autism has so many different flavours and things like that. I think using all the wonderful techniques and understanding that you're using for people with autism and emotional developmental conditions would benefit all of us having an interaction with healthcare.
That doctor really thought about that. He really thought how to best to approach him. Yeah.
It's wonderful. I've got Mabu and then Martha.
Thank you. Thank you very much. My name is Mahbub Khan. I'm a non-executive director here. And listening to the story that you explained to us this morning makes me feel really proud about the staff that we've got here, but also that compassionate care provided to your son made a huge difference to him as well. My daughter is quite old, but she's deaf. So I remember as a parent, 25 years ago, navigating through the complexities of the NHS and taking a deaf child or a child with special needs into hospital. It can be difficult for both parent and child as well. And when we agree our sort of strategy and stuff, and we've got a really strong approach towards patients with learning disabilities, hear from themselves. It sort of connects it from knowing that on paper, this is what we say we're going to do. That's what we do in reality.
Real reality, yeah.
So if there were any improvements you think we could make, I'm sorry to put you on the spot because we've been really positive, but we do always, there's always, room for improvement in anything that hospitals do. And as a board, we're very open to that. And as an organisation, we're open to learning. If you can't think of anything now, you can send that through later, but anything that you can share with us, we're very helpful. But you won't detract from the point that you had, that you're through and you sort of receive exceptional care.
Honestly, can't think of any way that could have been made any better.
Yeah.
I can't. I mean, there's nothing that everything.
Yeah.
When the phone calls were always, answered when I phoned up to speak to Vicky about something. She acted on it straight away. Yeah.
And I love the fact that the doctor did sign language.
Yeah.
Yeah. That means
He did.
they went well beyond. what
He
you'd
thought
expect.
about. He thought about how to approach him, and he went. Yeah.
Right, that is brilliant.
Yeah.
Our last one, I think, is going to be Marta.
Thank you. I'm really inspired by the treatment that our colleagues have actually given you and your son. My name is Marta Phillips. I'm a non-executive board member. I don't have any medical background at all. So one of the thoughts that came into my head is that the treatment plan that you were on was an appointment during the day. And I've heard Fiona mention about the flagging and the passport system. But I'm just wondering, even with that, if we have someone coming who can access emergency at night, how do we as an organisation support them and support our staff?
Yeah.
Or what mechanism? Because I'm sort of assuming that because of the kind of service that you and your team offer, it's very much a sort of daytime weekday service. So I'm just wondering about the weekends and the overnight support that we're able to provide as an organisation.
Yeah, so that's a really good point. We are a 9 to 5 corporate service, so we're not here on the weekends, we're not here in the evenings, and we're not here on bank holidays. So two of the ways to sort of safeguard the patients in those times is, I have to say, exceptional level 3 training. I've been going along to either deliver it or watch when I was new, and I can say that the training, the compliance rate in terms of the training has improved. The training itself is very, very thorough. It's very interactive, gives people a chance to have a real life simulation of what it's going to be like. And I think A&E staff they have kit days, like we're doing a kit day every week. So we're constantly reminding A&E staff about the training, about reasonable adjustments and how to implement them. The other thing I can comment on is I've actually just completed the A&E checklist audit. So for our compliance has gone up. So it was brought out for that reason. It's a checklist that staff fill out when they identify that the patient has either a disability or is autistic. And they fill it out and they go along, it mentions like hospital passport communication needs. And then they send that to us to refer the patient to us. So in that checklist, it covers a lot of the patient's care that we would go and say, let's implement this, let's implement that. So in that checklist, it's about reasonable adjustments, it's about asking the patient for patient-centered care, it's looking at the passport. And because they're checking all those things, by default, they're providing that wraparound care for that patient in A&E until we can go. And I have to say, as a compliment, as someone who's new to the trust, I trained here a long time ago. I used to work here, but I have to say the care that our patients get in A&E as a new member of staff, when I'm going down with my colleagues, when I get there, everything's done. Like I'm just a little bit of an extra safety buffer to make sure that there are odd cases where it's a very busy department, or maybe they haven't got carer with them, so we haven't necessarily done what we need to do. But overall, because of the training and because of the checklist, I feel like A&E is one of our best performing units when it comes to our patients. They really go above and beyond to provide cubicles, make sure that what the patient needs is met. That's another thing we're really pushing out. When I said that we're trying to make practitioners more autonomous, we're trying to say, you know, not everybody needs every adjustment, and sometimes it's about the patient. So speak to the patient, ask the patient, advocate for them, and make those adjustments. And then if there's an issue, the idea would be to call us. So we're trying to make people more autonomous. And I think I have to say, I believe that Amy is one of our best performing areas with our patients, just because of the checklist and because of the training.
It's really good to hear. Thank you very much.
So good to hit Diane and Heather, thank you so much for coming along. Really helpful. It's always good to hear a positive story. And as Luke said, it does make you feel really proud of the care that the trust provides. So lovely to hear how good it's been for you. And I'm really glad that Christopher's done so well.
Thank you very much.
Thank you. Thank you very much.
Okay, thank you. That was excellent. Brilliant way to start our meeting. Really uplifting story. So, back to the more ordinary thing today. Are there any declarations of interest for items on the agenda today? Okay, we have the minutes from the meeting on the 6th of March. Any comments or amendments to make for those? Are we happy to approve?
Yes.
Thank you. Good. Matters arising, there weren't any matters arising. I don't think there are. That we need to worry about. Action tracker. There's only one item that's open, not due today, and that's a board seminar on productivity has been scheduled for the 5th of June. So we'll deal with that when we get there. So, chair's report. I've got a couple of sort of formal items to update on. The first, in terms of our board membership, obviously, and we already welcomed Nick, and just formally to note that Nick has joined us as our new chief nurse. And is very welcome, and also delighted to report formally in our public board that we've been successful in extending Sue for a further 3-year period as an executive director. Absolute accolade of what a valuable member of the team she is, that I didn't think we'd get the full 3 years and it was signed off. So lots of support and absolutely appropriate. So delighted, and thank you, Sue, for being so willing. Just in terms of what I'm seeing and doing, I'm continuing with my induction, which means Chris keeps me absolutely busy back to back every day as possible and meeting people. And I have continued to have some really positive meetings. I'm still meeting, well, I think I've probably been all the way through now the triumvirates for all of our departments, and lots of visits on each site, meeting different teams, seeing different wards, and all absolutely sort of gobsmacking in terms of it's so I am still like a kid in a sweetie shop and really enjoying it. So much to see, but really fabulous people everywhere I go. External meetings as well. So I think I've met all of the Health Watch leads for our local area now and had some really positive conversations with all of them. I met our Freedom to Speak Up Guardian, obviously an external service, really interesting to hear how that works. So that went very well. The chaplaincy team was particularly lovely team to meet and spent a bit of time meeting all of them, and what a positive bunch and creative as well, just really warm people, so passionate and committed and providing really great service for staff and patients and families, of course. So that was excellent. I mentioned earlier, I've been to see the charity team. That was great. I also met with the staff network chairs. And shortly after meeting our network chairs, then we have a joint every so often meeting with the BARTS network chairs. So Ian, their new chair, and me joined that meeting. We'll continue to do so. And just really interesting to hear that shared learning across both trusts. I think that works really well. And then the sort of most recent highlight, I thought, yesterday when I visited gynae ED and then children's ED, and was able to see the place of safety that's just about to open for children who are going down the mental health path. who've come into ED, and it's absolutely amazing. Just so well designed, really thoughtful design, and a really valuable space. So it's really excellent to see that. In terms of sort of broader national events, there's been, as you might know, quite a lot going on at the minute in terms of the NHS. So I seem to have been at NHSE, NHSP, NHS Confed meetings. I think I'm seeing either Jim or Penny Dash everywhere I go, and Matthew, I'm sure, will tell you the same. So lots of conversation about just the challenges and changes going on within the NHS. Now I'll leave Matthew perhaps go into more of that. But I think one of the really noticeable things is the impact it's having on our colleagues in the ICB. There's been a number of ICB meetings since, and obviously they've got a lot of challenges to face, but there are a lot of people who as individuals are facing a really uncertain time in terms of what it means for them personally. People are going to be losing jobs at the ICB, and I think that's just something that we need to be really mindful of and sensitive to, actually, because they are all dealing with day-to-day and a lot of pressures and personal worry, which is never an easy place to find themselves. More broader than that in the system, I think Mary Elford at Homerton and obviously Ian Jacobs landing well as new chairs. We've had a few get-togethers and finding ourselves obviously alongside each other at a number of meetings. And since Mary arrived, we've had our first APC joint committee meeting, by the collaborative. And I think that will now kind of refocus, it's already started to refocus on where that will go in terms of the clinical priorities, particularly focusing on gynecology and ENT as areas that we can perhaps work together to drive some improvements to North East London as a whole. And then looking again at some of these back office opportunities for greater efficiency and working together and shared resourcing, and thinking about some of the staff harmonisation, so we're not teaching each other or pushing prices up on bank staff, agency staff and so on. So I think some positive feelings that will move to be a more productive, operational, collaborative, and I think that's a positive thing. I might leave it there for now and let Matthew pick up on some of the other stuff that's going on in the system, otherwise we'll be duplicating, I'm sure.
Thank you, Chair. So there's lots of information in the Chief Exec's report, which I hope people find useful, including some updates on the really strong staff survey response. We had the good rating from Ofsted for our apprenticeship and careers hub, which we're delighted about, and the increase in salary also for St Barbara's paid work with abandonment and healthcare assistance as well, and an update on our campaign for the new A&E at Queen's. I think one of the most sort of challenging things we're dealing with at the minute is the financial and operational context and how the two things balance out together. Earlier this week I was at National NHS Leaders event with Jim Mankin, so we're very much emphasising the 10-year plans come in. We know what's going to be in it, largely around the 3 shifts. In the meantime, we've got significant operational pressures to balance up against the challenging financial environment, and that's kind of the job for this year, and to get ready for what comes out of the 10-year plan and the partnership work we need to do to make this a reality. So it's going to be a tough year on this, and the savings programme we need to deliver this year is a scale we've not had to do before. There's a lot in our favour, so we put in an operating plan for this year that says we'll meet every one of the targets that's been specified by the government. And when you talk to some of the staff who've been here for decades, they say the Trust's never done that before. It's never been in a position before. They say that we'll hit those targets with cancer, waiting list times, urgent emergency care, etc. So that's a really strong place to be. That's in the context of huge pressure on A&E. March was the busiest month we've ever recorded in the history of the Trust. We know from figures this morning that April was the busiest April the Trust's ever faced as well. And there's other things going on, like in the last 12 months, we've done 20% more operations at King George than in the previous year as well, using those extra theatres here. So both in terms of emergency care and planned care, both sites are busier than they've ever been in their history. And that's great in terms of activity overall, but actually that puts some real pressure on some of our services as well. So in the last 2 years, we've had to take out £30 million worth of savings. Now, our budget for this year is £1 billion. That's up from £930 million last year, and actually up from £550 million in 2019. So BHRET has the biggest budget it's ever had in its history. We've never had this much money to spend on healthcare, but the demand, as I said, is increasing, and our costs have gone up as well. So 25,000 more people coming through A&E, 20% more operations, places pressures on that cost base. Our focus is on meeting this government expectation that trusts balance their books in the way that local authorities have had to do for many years, and for us to no longer run a deficit as the trust become used to doing. So the £61 million we're going to have to save this year, that's in the board papers. That means roughly around £5 million less each month than it will currently cost us to run the hospitals. So our budget has grown. The budget's the biggest it's ever been. Our costs have also grown, so therefore we need to make savings to make those two numbers balance out together. And we're going to do a number of things to try to help achieve this. We're going to reduce our headcount, and our headcount is in the region of 9,000 people. And we're going to take out around 115 full-time equivalent posts in our corporate services. And that's a reduction of around 8% in corporate services. And that's consistent with the national benchmarking packs that have been sent by NHS England that says we need to take costs out in corporate. And that'll be a combination of redundancies and removing vacant posts. So it's 115 posts. That doesn't mean 115 people will lose their jobs. It means 115 posts. Some of them will be people who will lose their jobs. But actually, there's also, in my team, there's 2 posts that I haven't filled for a year. We'll remove those posts and find savings from that. So no one will be made redundant from my team, but we'll take 2 posts out of the team. So there's different numbers here. But that combination of redundancies and removing posts will save us around £7.5 million. That's on top of the £3.5 million we saved last year when we took out 40 posts. Again, posts, not necessarily all people. The other area we're going after is the amount we spend on temporary staff as well. And because we've started to make some real progress in how we're viewed externally, we've become a more attractive employer. We've got the highest number of substantive staff we've ever had. In areas like Band 5 nursing, where we've historically had some real shortfalls, we're in a really strong position there. A number of the medical specialties that we just couldn't recruit to 2 or 3 years ago, we're now getting really strong fields for them. We're getting really high caliber candidates across the board. The problem we've had is that while we've been increasing the substantive staffing, we've continued to use significant numbers of bank staff. In the financial year just finished, we spent £84.4 million on bank and agency staff. Now, there's been some real improvements in there. I think our agency staff spent two years ago just was £47 million. Last year it was down to about 14 or 15. Mike, is
Spent 18.
18 last year. Okay. So, but that's down by around £30 million on agency staff, which is really positive progress. But what we intend to do is cut those additional shifts further by around a third, and that will help us reduce our pay bill by in the region of £40 million over the course of this year. So we're going to offer bank shifts to permanent staff before those who only do bank work at the trust, and we've set up a daily bank and agency tracker so we can look in real time at our bank usage and step in to understand why services are using more bank than we expect them to if they are doing. So the key area we're going to go after is bank and agency usage to try to cut that spend. So that doesn't involve making any posts redundant. It doesn't involve making any people redundant, but it means taking out shifts from the clinical pool, and therefore there'll be less shifts available and we'll spend less money on that as well. We're heading into summer. It's probably what we're doing today. What that means is that a number of the seasonal illnesses we see in winter have fallen off, and that gives us a bit of freedom to do some work with our bed capacity. We're closing the equivalent of 2 adult inpatient wards over the course of the summer, so one at King George and one at Queen's, which takes out around 60 beds. That gives us the opportunity to do some maintenance issues, upgrade the wards to the benefit of patient and staff, and then gives us winter escalation capacity. This is something hospitals always used to do. We've fallen out the habit during COVID, but actually to have a winter escalation ward when you hit January is a hugely valuable thing to do in terms of managing pressure. So we're going to do that. We're going to close, we've already closed the one ward on either side. And that helps us also reduce our temporary staffing costs as well. And as we've done before, during less busy months, we've closed 8 paediatric respiratory beds here at King George Hospital as well. They will reopen in the winter. And that saves us about £15,000 a week and is reviewed weekly by clinicians as well. And that respiratory capacity here will come back on stream when we hit the autumn again to deal with those children's respiratory illnesses. You can see in the data a really sharp spike in children's respiratory illnesses in the autumn. And we'll have those beds ready for those children then. And just to absolutely assure people, residents will be able to access consultant-led emergency services for children and adults at our 2 main hospitals. Absolutely no change to that in any prospect. We will not change that. But these temporary ward moves will save us about £6 million as well, in addition to helping the bank and agency. There's other initiatives we're working on. For procurement, we're looking at standardising purchasing, working with Barts and Homerton. We think we can pull out about £5 million from the cost of procurement this year. And we think we can reduce our drugs bill by around £2 million by sticking to national guidance and working on clinical protocols. We think we can pull £1 million out of PFI contracts at Queen's, about £2.7 million by renegotiating contracts for out of hours radiology and scan reporting that we've previously contracted out. We can bring that back in-house. We're renegotiating the price of our products in pathology, which we think will save us about £2 million as well. And we're working with primary care colleagues around some tests of limited clinical value. And we need to understand the impacts of this. But for example, we spend £4 million a year testing vitamin D. With a consumer's face, we could probably give vitamin D supplements to everyone in the patch for less than £4 million, you know. So it's one of those tests where actually the value of it is questionable. We need to understand whether that habit that we've fallen into doing that testing makes sense in this economic environment. We are working on more savings plans, and we'll share details of any of those at a future board meeting. But our focus, temporary staffing spend, procurements and contracts for now. We will know as of next Thursday what our month one bank and agency position is like. And if we find as we get into the later stages of the year that we need to go harder on this, we'll have to come back with further plans. But I think the banking agency area is the one we want to go after really hard. So I'm conscious this is tough for our staff, because we do have significant numbers of staff who do rely quite heavily on bank shifts. And over the last few years in particular, there's many of our workforce whose working patterns are based around a couple of fixed days and then picking up prospective bank shifts. And with the changes we're making, and also in Barts, Mid-South Essex, etc., there are much fewer bank shifts around. And so that will mean for some people looking at their contractual arrangements with us, thinking about how they want to do their workload, etc., and to make sure we work around that. And we're really conscious of that. And we're also going to work really hard to mitigate any risk to patients as best we can, and to make sure we've got clinical staff delivering good quality care in the right environment. And the goal of this, though, is to end the year with no deficit. The prize from that is to become financially solvent organisation and to get away from the spectre of special measures as well. You know, for the last 10 years, trusts like these have been able to run in a situation where in local authority or in the private sector, you basically bankrupt because if you spend far more money than your income, there's a clear message at the minute that's no longer acceptable in the NHS. Our goal this year, with more money to spend than we've ever had before, but with growing costs, is to try to mitigate that impact on us as best we can using some of those measures that I've talked about. I think that's just something I know people are interested in that, and I know staff colleagues are interested in that. That's the position we're in at the end of month one. But I hope as you look through the rest of our report, you can see some of the really good stuff we're on, fantastic performance on waiting lists, cancer performance, and despite how challenging the environment is, particularly in the emergency department, and we are making some really good progress. And finally, it'd be remiss just not to say we had a lovely leaving day yesterday for our outgoing chief nurse, Catherine Halford. Welcome, Nick, as a new member of the team as well. But I think I was conscious last night, it's the first time in 9.5 years that Catherine wasn't on phone. If we had any issues, lovely to have Nick here. Take up that man. Thank you to everyone who participated in a great send-off for it. Thank you.
Thank you. Are there any questions from anyone? Yes, Martin.
Thank you. Thanks for the written report, Matthew, and also thanks for the comments you've just made. It's clear that we are moving into a very, very challenging year. I just wanted to ask a question on the reductions of the corporate services area. I absolutely get that we need to make the reductions. My question is, have we looked through to our activities and decided which activities that currently take place in corporate services will stop? Because to me, there's a significant risk of overstretch if we continue to do what we've always done. We can't continue to do what we've always done with reduced resources. I know that technology will help, but one of the tough decisions, or some of the tough decisions, will be how do we streamline particularly our information processes so we can actually reduce the workload to fit the capacity we can.
Okay, so corporate services, although they're facing cuts, they're a hugely valuable part of what we do. If you look at things like the improvement in our retention, in our staff survey, you can tie all kinds of things together to areas where we've made investment. So we've invested more resource in people, in OD, in workforce improvement. Our retention's improved through the way that team works with the clinical groups, etc. So, and the thing you always want to avoid in a trust is removing corporate services or management roles or administrative roles and expecting clinicians to pick up the slack. Because it's extremely wasteful to ask experienced clinical staff to do administrative work in the interests of being able to say you've cut management costs. And actually, if you are on a hospital waiting list, one of the things that means you get seen on time is good quality management. It's administrative staff doing the job properly, etc. So we need to be very careful. This isn't a kind of corporate services, bad, clinical services, good environment. The best you get is when the two things work together really effectively. So, Marta, when we're looking at where we take this money out, we're looking at whether there's capacity elsewhere in the organisation to pick up some of the slack. And we're looking at areas where we've been able to not spend on something for a year or two and take those posts out, as in the case of my team. And we're also looking at areas where we've got stronger leadership in the clinical groups, where they're now able to run the services locally through a business partner model, rather than through a central corporate service as well. So, for example, Mike and the finance team in continuous improvement, in HR and workforce at the minute, what we're trying to do is devolve as much responsibility to the local clinical groups so they can run more of their own business as well. So it's a fine series of judgments. We may find that some areas in the next year or two it becomes obvious we've done too much. I think that's always the risk with that you end up with people saying we're not doing this anymore. Too much of it's falling on the wrong people. So it'll be a finely balanced thing, but all these processes happen through local consultation, assessment of work make the biggest difference. But we need to make sure we don't end up doing down the value that management, good quality administration and business support plays in an organisation like ours.
Right. Going to move us on, and I think it's you again, Matthew, going to write a cute spider account.
Yep, there's a paper in the pack, which is an update on where we're going in collaboration with Barts and the Homerton. The three trusts at the minute are very focused, obviously, on dealing with the financial challenges and linear operational challenges that we're dealing with. So we've had a couple of conversations about what our priorities should be for 25-26 in the context of that. There's sort of two broad areas. One is about corporate services collaboration. I've already mentioned procurement. Some of the savings we'll make in procurement is as a consequence of us working much more closely with Barts and Homerton and potentially with mental health and community colleagues to make sure that the billions of pounds the NHS spend in North East London gets the best value out of that as well. And we're looking really there at the procurement side. And Janine and our Chief People Officer colleagues are having some really good, transparent conversations about rates, about savings opportunities, and potentially about where we can share functions. Because in some contexts, it doesn't make a great deal of sense for us to have multiple functions doing the same thing in every provider in North East London, where we can work together and deliver better value. So we're open to those kinds of conversations about. And we're also looking at clinically sustainable services. I was on my board walk around this morning. We went to cardiology, which I think is a great example of fantastic network services in North East London, where you've got Barts and BHIT working really, really well together to get patients access to world-class specialist care at St. Barts, but also being able to access fantastic local care through King George and Queen's Hospital. And we're looking at how we can build up some more clinically sustainable services. And initially, we're going to look at ENT and gynecology and see if there's more we can do together. In recent years, the Homerton's helped us with our gynae waiting lists, etc. We've picked up ENT patients from other parts of North East London. So we want to see where there's more clinical opportunity there to push it forward. And we're developing a multi-year proposal for this, but I think it's fair to say that in the current financial and operational context, anything we do in collaboration has to be clearly value adding. It has to get better care for our patients, better value for the taxpayer, and it has to justify the outlay of leadership time and input we put into it as well. And I think this revised set proposals from the APC takes us into that space.
Yeah, thank you. I've read a lot of the stuff on the APC and where it's going and how good it all seems to be. But one of the things that I haven't seen any mention of in there anywhere is any patient representation on the APC. And in this day and age where the NHS is quite keen that patients are involved in the formulation of our services, I think that's an mission.
I think that's it. I think it's a really good point, and I think particularly around the clinical sustainable services programs, it'd be well worth us looking at how we bring the patient voice into that. So I think some of the other areas like the procurement stuff, I'm not sure. You run the risk of creating a tokenistic role for someone to enter a very technical conversation, but I think certainly things like ENT, gynecology, there's a really clear space for that. So we'll take that background. It's a good suggestion. Thank you.
Thank you.
Asim. Thank you. Thanks for the report around the APC. It will come as no surprise to you, I suspect, that my question is about the other organisations in our health system and how we would collaborate, not necessarily more formally, but in a way that we get feedback, particularly given the challenges we have with patients in A&E. So I'd just like to hear a bit about how we're going to take that forward as well, please.
Yeah, so I mean, I think when provider collaboratives were set up, people took different decisions about how they get structured. And there's some parts of the country where they've gone for much more place-based provider collaboratives with mental health, community services, primary care and acute care working together on a population basis. The decision was taken in North East London for it to run by provider type across a broader patch, which is fairly common across London actually. So the focus to date of our collaboration has been acute, as it says there. That's useful when you're talking about things like procurement or about some of the more network specialised care. But it has at times meant that NELFT, North East London Foundation Trust, to deliver our local community mental health services and who day to day we have far more interaction with. They're in a collaborative with East London Foundation Trust. And I think sometimes that means there's an artificial barrier between the conversation between the acute and mental health and community that isn't always had. And I think we're doing more to try to have those cross collaboration conversations. You know, if you went into A&E here today, what you would find is patients who are under NELF's care, patients who are definitely under the care of general practice and probably have interaction with local authorities around here. And the acute provider collaborative doesn't go into that kind of space. And that's one of the reasons we've got the revised scope here. The next conversation is how we make the place-based conversation work.
Right, let's move on. I think that, we're going to get maternity services update, which I think we've got Frankie, we've got Abby on, and we've got Catherine online. We'll let me hand over to the maternity services team and to the update. Thank you.
Hello, good afternoon, everybody. My name is Abby Chinadu. I'm the Director of Midwifery and Director of Nurses for Women's Services. And I've got Catherine online. She's
Catherine, we can see
it. So I'm just going to be presenting the key highlights from our paper today. I believe everybody has seen the paper already. So the key highlights of our report today is in terms of things that are for noting as in the first page. During the Q3 of our maternity service, the findings from our perinatal review, we had 8 perinatal deaths during the Q3. It's just for a notification that all these cases have been reviewed both internally and externally, because that is part of the system nationally. So we have presented these cases through our governance processes in maternity assurance organizing, in maternity safety champion. We presented it in NEL as well, and some of these have been presented in QUAC, and we get all the scrutiny in terms of this. The appendix 6 is in appendix 1. All the actions that we've taken has also gone through our internal and governance processes as well, and it's being monitored in those cases. So out of those 8, 5 of those perinatal deaths had no care and service delivery issues at all. 3 of the service and care delivery issues were not identified, and they didn't contribute to any of those cases at all. This is the first time we're having that. We're quite happy about that. And what I can say regarding this as well is in terms of the progress we are making, in terms of the review, we still have challenges, but the themes that we were faced with last year are not what we're facing this year. Because when compared to last year, we had a lot of issues in terms of escalation, TTG, and things like that. Quite different because of some of the interventions we have actually made. I'll just say there's progress that has been made there. Then yearly, we've made progress as well. In terms of our maternity and national safety investigations for Q3, we have reported in line with the national requirements regarding that. And I'm happy to say that we actually met the requirements nationally. And what we've put in place that is now mandatory in year 7 of maternity incentive scheme is getting the feedback from our women, which we have started ahead. We didn't know that we're going to make it compulsory, but we started ahead last year through a thematic review to ensure that women that have had these 4 outcomes, what can we learn from them? So now it's going to be part of mandatory thing for this NIS, but we're a bit ahead of that. So some of the things we've encouraged families in terms of telling us what their feedback are in terms of things that have gone wrong, have gone well in these circumstances. Then additionally, one of the things that the trust has done is the patient panel, which maternity is part of them, and we're going to be having a patient panel for maternity next year, in June next month. In part of Q3, these are some of the number of incidences that has been logged. And we can see in terms of these incidences, most of our incidences that are moderate and above, we do present them in the incident learning oversight group. And these are also presented in some of those quality assurance meetings that I've spoken about. And we present it at the safety meeting in LMNS as well. And Maternity Assurance Board has an oversight for it and other groups in terms of our governance. The top 3 incidences reported in moderate are actually 3rd and 4th degree tear, postpartum hemorrhage, late fetal loss. So in terms of that, we've done a lot of work regarding that. In terms of the 3rd and 4th degree tear, we are doing KY projects so that we can learn more and see what we can do. Postpartum hemorrhages, because we changed the goalpost of our induction of labor last year, just to meet the national guidance, and our C-section rate has increased from like 2 years ago, which was less than 30%. It's now almost about 50% of women are having C-section rates. So it's showing that our clientele have changed and the complexity of our women are changing as well. So we're doing a lot of work, and there's going to be work nationally as well regarding how to manage postpartum hemorrhage better. In terms of the late fetal loss, we have a lot of work to do in terms of the community we're serving because of the diversity of our clients. We, as the units, we are trying as much as possible for women to present early, but some of our women are still not presenting early, which we have to work on in terms of putting system in place for them to be able to present early, because some of them are waiting for their partners to come back from work when they're not feeling their baby move quickly and things like that. So we're working on that. And we've put system in place now that we started induction of labor parent education, and we're going to be doing it in different languages so that we can meet these clients. Our maternity patient safety team, we've increased them by 1 staff. It's part of it's not additional funding. It's part of the funding we have. So we're just using them separately. We're just using them separately to ensure we're able to meet the needs of our clients, especially in clients in IG1 and RM10. Then we've put specifically enhanced continuity of care in those areas, because up until last week, we're still picking women that are coming to the country for about 3-4 months that have not presented in our services. So it's about educating people on this one. So the action and teams, we are triangulating our actions and teams against our complaints, and just to see what we can learn from it as a unit. Our training compliance, our MDT, at the end of the MIS year, all our MDT, they were able to reach the 90% attendance. I know Martha is there. We had a lot of challenges getting into that place, but we've worked on it. And this year, with some proactive people that have joined the team as well, for the areas where we had the challenges were in terms of our medical colleagues last year, that is going to be changing for us going forward. So in terms of our midwifery vacancy, as we all know, and some of you that doesn't know, we had a birth rate plus last year, and there's an increase in terms of our birth rate plus. So we've managed to recruit into our birth rate plus funding as much as possible. The vacancy we have now is quite low compared to where we are last year. Initially, we're even thinking that our students are going to be qualifying this year, September, October. We may not have enough positions for them. But hopefully, as times are going on, because on a month by month, we lose a midwife or two to either promotion or they're moving out of the area because we have a young workforce. This has also been presented in the maternity safety champion meeting in terms of our midwifery workforce and in terms of obstetric and neonatal workforce. Our midwifery fill rate is, as you've seen there, and we're working a lot in terms of retention. We have our service user feedback, which is we're working on, and we keep taking the feedback in terms of what we need to improve on. Safety champion feedback is as documented. We have a lot of floor works in terms of, we have a NED that does the floor work. We have a midwifery and obstetric workforce, midwifery safety champion that walk the floor. We've done a lot of work in our progress on culture and behavior program, which the quad have led on. We spoke to over 179 staff face to face, and we're still doing ongoing work so that we're hearing the voices of our staff and the voices of our women. As you can see as well, we had an announced CQC visit in October last year. And at the time that CQC came, some of the key issues that is highlighted, I would just like to say that we got a draft CQC report just to check for the factual accuracy. The key issues that have been identified is mainly to do with flow across the whole units, which is a big thing for us. Then in terms of some of the staff, both in our triage area and some environmental work, and in terms of some of the things that they pick up, which we're challenging on, is in terms of our governance processes, which I don't think anybody opened that aspect or spoke to us regarding our governance processes at the time. But we've done a lot of work, and we continue to do a lot of work because we're almost exiting our MSSP program by the time they came. And we're getting a lot of support, both regionally and nationally, to sort of deal with this challenge. But we are expecting CQC to visit us late summer. That's what they've told us because of these issues. But we've done a lot of work, and we continue to continue on it. We had 2 coroner spaces, and we've attended one, and we have one planned for June. And there's 2 that have happened in October and November. In terms of the maternity incentive scheme for year 6, we achieve all the 10 safety actions. We are not just talking in terms of achieving things now, in terms of the safety actions, because what safety means for CQC is different from what safety is meaning for MNSI. So at times it's a bit difficult to look at what people are really wanting. So we have a lot of work that we're doing, even though we've achieved this, is to continue, not just as a tick, it's not a tick box for us, is to ensure we have sustainability process in place to ensure that we're monitoring what safety is. In terms of our Saving Babies version 3, within now we are achieving that at 94% compliance. And what we said to Nell, this will vary because it's not a tick time box, things changes, and there are a lot of things that we need to be picking up and improving on. So the other thing is in terms of avoidable term admission, which is our 10 program that we're being monitored against nationally. But for year 7 CNST requirement, that they will be dropping. We've always been within the target and lower than the national target that we're supposed to be achieving. And part of that, the top 3 reasons for admission for TC, transitional care babies, is mainly babies requiring phototherapies for jaundice, babies requiring IVs for suspected sepsis, readmission from the community due to jaundice. We're going to be working with our neonatal colleague to see if some of these services can be taken outside the trust, just to help us with our flow, because there are some trusts that are doing IV antibiotics at home and things like that. Finally, I'll just say that the things for escalation are as documented in the reports. Thank you.
Happy, thank you. It's really comprehensive and that really good run through of where things are and some positive moves, things standing strong. Good. A lot of work on putting up on and continue on the CQC findings and so on already in the case this week. And that's Leslie.
Yes, thanks, Abby. That was really comprehensive reports. Just a couple of issues that struck me. One was the table which talked in the first section, which was really looking at health inequality. And the percentage of births that were stillbirths for Asian and Bangladeshi was quite disproportionate to the number of births compared, the others were very consistent at 0.7, but that was 1.19. And also a couple of times during the report, it mentioned, one case it was wording was, I think, persistent problems with translation services. So I just wondered what we were doing about translation services and what actions we're taking around that disproportionality, around the percentage of births that were stillbirths among that particular population group.
Thank you so much. In terms of that area, we're doing ongoing thematic review amongst our women, hence we're able to detect in terms of those things. So what we've done, we did a mapping last year, and it sort of showed that areas that these women are populated is mainly IG1 and RM10. So what we put in that area is enhanced continuity of care team. And since we put it in, I'm sorry, it's not in this report, it has reduced the stillbirth rate there by 35%. We know the enhanced continuity of care team is mostly part of the contributing factor because the midwives have more time to spend with these women and are able to get they make sure that there's interpreting services for those women. But we're not yet able to cover all the women because we're just replicating prior that to see the impact. And that's the impact that we've gone from that intervention. So we'll be rolling more teams to be helping us with that. And our maternity patient experience team are also working in that area to see what else we can do to improve this. Our picture sort of fit with the national picture, but we're working on it to improve on it. In terms of our translation service, is a big issue for us and is a big issue within NEL as well, because the services we're using at times, most times you get the translators. Initially, it was part of the reception in some of the areas, which we've been supported, and that has improved. But we're working on it to keep on improving in terms of the translation services. And NEL as a whole, we're working together to move this forward.
We're getting a little time. I've got Maboob and then David.
Leslie's asked one of the questions I was going to pose, but can I ask on that particular table, if we could have a look at the descriptions across the top, because the description of Asian Bangladeshi doesn't align with what I'm looking at, what you're trying to describe there. If you're trying to describe patients from an ancestry in the Indian subcontinent, then mentioning Bangladesh there doesn't actually describe that unless there's another reason behind it. Jenny's hands are up.
I think that's actually the specific ethnic group. So within our data patches, we're able to roll up, but then also disaggregate. And I think for these purposes, it's actually really important that when we're talking about inequalities, that we be as specific as possible.
Because there isn't one here for Asian Pakistani, Asian Indian, or Asian other, then that's why we asked that question. So it's good to compare across these. On the response you gave to Leslie, I'm really interested to know is if you could have further engagement with the public health teams across the piece and also with women themselves and understand the issues and challenges there, because we know there is a widening gap in inequalities, cost of living crisis, post COVID recovery in working these populations. But we see it presented here, but we need to go upstream if we families. And then the other thing that refers to an improvement plan, section 3 as at appendix 3. And I can't see the improvement plan, so it's not here, but I'm grateful if you could circulate it to board members, please.
Thank you. Yeah, so we are getting very tight on time. Does this report go to Quality Assurance Committee as well? It goes over length. So I think see a lot of detail can be explored there. So I've got 2 more questions, then I'm going to move us on. So David and then Ron, but we're going to keep it quick.
Yeah, just with regards to translation services, has that issue been resolved or is that an ongoing pressure?
It's an ongoing issue. but some of it has been resolved in terms of the reception in the areas. That's improved compared to where we were before.
We are looking at trialing some pocket translation devices, so I'll loop you in.
And I think Kerry was coming in and.
So yeah, just so risk is on the risk register for translation services specifically related to maternity, and the maternity assurance board is picking this up as an action. So that's reflected in the last minutes, and an action was assigned to pick it up in the next maternity assurance board.
You're talking about patient feedback and collecting that. You have a dedicated patient partner in women's and maternity. I've not seen any mention. Their job is primarily to talk to patients and feedback the information to you. And I would have expected to see something in there that is actually working. Is that not working?
I'm not saying it's not working, it's working. So we just put this as a summary in terms of the patient feedback. Is both from our patient partners and our team that are working the floor and our maternity patient experience team. So it is working.
If it wasn't working, there's something that I can pick up and do
It's
something
working.
about. Okay, thank you.
Apologies.
Thank you.
Sorry, Sarah, I know you want to close this item, but just to flag up, theatre space has been an issue with maternity for some time. If the portion of cesarean sections is going to increase, we need to look at that further.
Yeah. Looking into, but we won't go into detail here. Thank you, and Abby, thank you very much for taking us through that so much detail. Right, we are going to have to speak for a couple of minutes. We're already fairly behind. Let's move on to the Quality Assurance Committee. And I think Martin will hand it in to this with Hilary doing.
Thanks. I'm only going to make two comments on the report relating to the units where the Quality Assurance Committee gave partial assurance. One is on pharmacy. We're expecting that to improve because there's some new systems which are going to be delivered at some point, which will improve the way in which medicines can be delivered from the system. And the other one is on the urinary tract infection service. We think the issues there will eventually be resolved. We've been on our payroll a medical examiner, which will help us to look at some of the issues because it relates to elderly patients. And I'll try and answer any other questions that colleagues might have.
Thank you very much. That's really it's good to hear that those matters are being addressed and will be. We expect to see those improve. Any other questions based on the report or from those who were at the meeting? Lovely. Well, that does help with speeding things along. Thank you very much. Okay, let's move on then to the specific papers, and I think Cheryl, we might finally pick up on these. So the patient safety incident overflexious. Please, in the first one.
Yeah, thank you, Chair. So presenting the patient safety incident response framework plan and policies. This is year 2 on behalf of Nick. And so as colleagues might have seen already in the QUAC report, so TEC and QUAC have already reviewed and endorsed this policy and plan. So we're just now asking formally for the board to approve so we can move into the implementation, which we want to start today. And so as the board will recall, we implemented PSERF in October 23 as a replacement of the serious incident framework in line with what NHS England expect us to do. Over the past 12 months, we've been able to embed new ways of learning from incidences, moving away from that blame culture that we saw that sort of came out of the serious incident framework, really into that learning culture with real increased family involvement and engagement. And this year 2 plan and policy reflects how we want to build on that foundation. It's the product of a colleague that's now moved on to the other roles, but Kira O'Regan working with huge amount of stakeholder engagement, both internal and external, patient partners, etc., virtual sessions, frontline staff engagements, and some really good feedback from staff and patients that have been part of those investigations. So this refined policy really does build on that in. And 3 key things to note, please. So we've got strengthened patient engagement in year 2. So making sure there's real positive checkpoints from patients to make sure that they're fully involved in those investigations. Improved governance. So we've strengthened the SOPs and the templates and things that people have got to use to make sure we've got governance taking us all the way through and having really good meetings to check in on it all. And then more responsive investigation methods. So formalise some of those investigation methods to make sure all staff are doing things that the way that we expect them to do with the patient engagement specifically. It's aligned to national best practice, aligned to what our stakeholders have said that they want. Just for the board's information, there's no additional financial requests or burden associated with this paper. The resource pool will be time, so it will be time for people to complete this investigations. So asking for approval of this paper today, please, Chair.
I just ask, obviously going into the second year now of this, how does it feel in terms of, does it feel that it's embedded throughout the organisation and people have made the switch and recognise where we're at now in terms of how issues, incidents are managed and the variety of learning methods from when something occurs? Is that becoming custom and practice and well understood right throughout the organisation?
Yeah, I believe it is. People tend to go naturally to the word PSERF now rather than SI. They tend to go naturally to the words patient safety investigation rather than SI. So I think, yes, if you'd ask sort of people about that, yes. What we need to embed is that learning bit. So I think where we're stuck is that action plans are still used quite a lot. We want to move into improvement plans. So that's where we want year 2 to take.
Any other comments or questions? Yes.
Yeah, we've been quite involved in that. Thank you, Kerry, for the involvement we've had as patients. And we've seen really dramatic improvement in the way that patients and families are involved in investigations. That's really, really good to see. From what you asked earlier, people I think are much more aware now of the different avenues that we have for investigating incidents when things do go wrong and the different ways that we can actually approach things in terms of fast track reviews, multidisciplinary teams, PSIIs and so on. And people have got a much better understanding now of what they all mean and for different outcomes and the different amount of resources that are actually required to actually service each of those pathways. So from the patient's point of view, as a patient representative, it's been a massive success story. So thank
That's
you.
really good to hear, especially it is such a big change. So to hear such a positive reaction so quickly really is really good. Thank you. Appreciate that. Okay, so if there are no more questions, we're being asked to approve this one. Are we happy to do so? Yep. Lovely. Thank you very much. And then we're moving on to the debts. So that's with Andrew.
Yeah, so you've got the paper here that you've read. Then we had just over 2,500 deaths in a year from the trust. And this paper looks at whether our numbers are as expected based on our case mix, age, so forth. And it's measured both by the SHIMI and the HSMR. And for both, for the SHIMI, we're just above where we should be there. Whereas for the HSMR, am I getting the wrong way around? So for the SHIMI, we're just below where we're around, but we're just below where we should be, and we're green for the HSMR, so we're where we should be. I can go into more detail if people want, but we look at alerts. So during a year, we will get alerts based on our outcomes for certain diagnostic groups, and that may lead to a deep dive to just investigate whether there is a significant problem or not. So the deep dives that we've done in the last year, we did one on UTIs, one on aspiration pneumonia, one on pneumonia generally, etc., as listed here. And based on those, we haven't found any really significant worrying problems, but we keep a close eye on anything that we're alerted to. And there's a neurosurgery one going on. We investigate deaths where there's a concern using the structured judgment set out by the Royal Colleges. We have a group of doctors who do that on our, so they're consultants who do that on behalf of the trust, and it was presented. Perhaps the biggest change has been the medical examiner's process. So previously, when a patient died, junior doctors would go to the bereavement office, sign a death certificate, maybe after having a discussion with a consultant. So question about what they should write. The bereavement team were indicating to them where they felt that more information was needed, and they, between the bereavement team and the doctor, who was signing and their consultant, they decided whether to refer to the coroner. Now all cases would go via the medical examiner, and that became a statutory requirement in September of last year. And that's led to a few problems. So as well as having a bereavement team, we now have a team of medical examiners and a medical examiners officer. So the bereavement team will then pass cases across to the medical examiners officer, who will then make sure to use the case, and then the final decision on whether a case can be signed off. Death is made or whether the case needs to be referred to the coroner, and that's caused some problems. It's added additional steps, and in particular has led to some delays in decisions being made, and that's a particular issue in our area because the number of Muslim and Jewish families where early burial is really very important to them culturally. And so we're working hard to make sure that we can reduce the time delay and making sure that we've got medical examiners available at the weekends, for instance, so that we can get an answer very quickly. We'll be changing things to some extent when we go to the EPR, so it'll all be electronically processed once the EPR is in place. But in the meantime, I've asked that the doctors return to seeing the bereavement officers as they used to, and make sure that bereavement officers will check the cause of death and whether they feel that the patient should be referred to the coroner stage, because the coroner was getting upset. They were hearing about cases quite late on. So we sent that in place in the last couple of weeks. I can feel that's still out of the delays. Answer more questions on the video. I think otherwise the paper is quite clear on what we're doing. That's just answer any questions anyone has.
Use my ignorance. Does that mean there are now two groups involved in deciding whether or not a death needs to be referred to the coroner?
So there are many cases where it's very obvious that death should be referred to the coroner right from the outset. And we want to make sure that happens when it's appropriate. Medical examiner then has a review of the case. And in most cases, they will agree that there's enough information to find a cause of death. But they can also have the option to say that this should be referred to the coroner. It adds an extra step. It's there to try and look for patterns and to make sure that we don't sign off deaths with a straightforward death certificate when actually they should have been referred to the coroner. So it has there's a significant and sensible reason for having medical examiners, but it has added an extra step and caused confusion.
And is it altering the outcome in terms of numbers that are referred and reasons for? So
It's probably too soon to know whether it's making a difference. It's likely to.
Nationally, yes. So nationally, so it first got started in 2017. So there's been a trial period for a long, long time before it's gone stock statutory. So nationally, they saw there was a really good reduction in the number of cases that were referred to coroner for unclear cause of death, because the medical examiner body could then sort of have a senior level conversation with the consultants involved in care, and they are senior doctors themselves. So that's the expectation. At the moment, our death referrals need improvement, so that's what the coroner's feeding back. So that's what Andrew's talking about in terms of that sort of, I don't know, settling in period, really.
Yeah. It used to be a very easy system where we had some very experienced bereavement officers who would say to the doctors coming to sign the certificate, hang on, this is one where we would usually have a discussion with the coroner's officer and refer them on. Now there's a new way of doing that, which isn't just a phone call. You have to fill out a form. And one of the issues was that the forms weren't filled out in detail. We were waiting till the medical examiner had dealt with the case, and everything was delayed. So we're trying to get the bereavement officer back involved to advise our junior doctors when they think there's an issue. Yeah, so and this Tuesday at 10, coroner's coming as a guest, so we can have a discussion with him, the senior team, which I think will be very helpful.
About 6 months ago, Mike and Matthew and myself went to Queen's Mortuary, and they were talking, the mortuary manager there was talking about care after death and post-mortems, particularly for the Muslim community, and looking at repurposing scanners as well that were coming to end of life elsewhere in the hospital as a way of speeding that up and stopping trips to Oxford and things for post-mortem. So I wondered if that idea had gone anywhere further.
It's still in discussion.
You're going to say, yeah.
To say, yeah, I would happily update you actually, because we had a mobile CT scanner, or semi-mobile CT scanner in ED that wasn't fit for purpose. And so what we have done is move that to a space with the appropriate lead lining and shielding, and now out of hours patients in the mortuary are taken up in the lift directly from the mortuary floor into the it's almost a dedicated CT scanner unit for those CTs. So we're actually able to repurpose a piece of equipment that's no longer in use clinically, and also provide a dedicated space for that activity rather than trying to carve out of hours time in the CT scanners that we use every day. So it's a really good story actually.
It's good to hear. I think the other thing about medical examining to touch on is that this is not just affecting the trust, this is now statutory across community as well, so all GP deaths are now coming in. And I think the data in a year or two time will be really interesting, because learning from deaths we've only ever done in hospital deaths. But actually we should probably be widening our scope and looking at deaths that happen quickly after hospital and what are the causes of those are. Did they have a palliative care review? Did we actually get them out at the time that they needed to be out, and was that appropriate? I think the other thing that's happened from the learning of deaths is, and I think it's the key thing about the medical examiner, is there has been a habit in the past of inappropriate causes of deaths being placed. And on the deep dive, things like urinary tract infections being put down despite absolutely no evidence of urinary tract infection. So as a trust, we should start to see better data coming in, which will very much support the EPR as well, because it all should link up. It's just too soon really to start pulling that data, but it's something, I think 18 months time we'll have a much better oversight of actual really causes of deaths and how we can combine that as a system rather than looking at a test alone.
Okay, moving on to the integrated quality and safety monthly.
So Kerry, you're going to take that one for us, I think.
Thank you, Chair. So, like to take the paper as read, it's appraised at various committees. And just to reflect briefly what it's showing us. So it's encouraging signs in some areas. So we're still seeing a really good instant reporting culture and high instant reporting rates signifies that our safety culture is strong. The report does talk about some persistence, but also some emerging challenges. So just like to draw the board's attention to another event, which was reported in March. This relates to an incorrect route administration of a medicine. The immediate response was robust, so we went down there and we've had an immediate debrief with the team. There's an appropriate investigation underway, but it does highlight a concern in terms of medication safety. So we will pick that up as a continuing improvement activity. There are also a number of overdue patient safety actions, which you'll see on the report. Each clinical group has got a plan, which is supported by a corporate colleague. So we have now assigned essentially what Ben will say about that business partner model. We've got a dedicated person in our corporate teams who are overseeing that improvement plan with the clinical group. Picking up a favourite of Ron's, which is the duty of candour and compliance, is okay for our moderate harms. That's the statutory duty of candour. Where we are falling below and where we want to improve is for those low harm cases. So now we monitor both. We look at where there has been no harm, but we should engage. We're looking at that, and that's low. So again, like I said about our PSA and really kind of focus that. I just want to quickly talk about pressure ulcers, because there is that concern where we are having some changes to our staffing models, perhaps, and whether that will reflect in terms of our harm-free care. So just assure the board we're keeping a really close eye on that. So yes, there's been an increase in perhaps some pressure ulcers and some falls. That is a bit reflective of reporting. So we just need to make sure that our tissue viability team are keeping a really close eye. that we're not double reporting instances. So for example, operationally, where patients have to move a couple of times, so from an A&E, from a assessment area to a ward, there's a risk that they're reporting that ulcer 3 times. So we just need to make sure that it's known, we're really getting into the data about that. And also, some people are reporting multiple pressure ulcers about the same, there's multiple pressure ulcers on the same patient, which they didn't used to do. So we've asked the tissue viability team to really deep dive into that data and present that through our committees for assurances. In summary, this is a reflection of what's been going on in the trust in terms of quality and safety.
Mentioned the duty of candor, some of those areas that bit of delay in response rate, but also I noticed some of the PSIIs and the architectural reviews overdue for completion. I just wondered whether action was being taken to sort that out and speed things up there.
Yeah, absolutely. So the feedback that we've had from the clinical groups and from the investigating officers is that it's the increased time that it takes now to do these investigations. So the PISA national framework says it takes up to 6 months. That's compared to the SI framework that was allowed 60 days. So is that extended amount of time allowed, but we're still going over, and that's been accounted to about for clinical pressures. So like I said, we have assigned a trajectory for each clinical group that holds these patient safety investigations to get them completed. And we are prioritising the most significant of those instances to make them get through. And we've implemented a review process whereby where we can de-escalate any of those patient safety investigations that now no longer fit our criteria or are thought to be, we may have been overzealous in reporting, we're de-escalating those down to AAR. So again, we can really prioritise on those instances that can lead to real improvements and learning.
Yeah, as Kerry said, one of my favourites is duty of candour. And I have to say, one of the problems has been there, duty of candour is very often actually carried out. It's being done, but it's just not being documented. We pick up a lot. So actually, we're better than we look, better than it seems we are. So that's quite encouraging. And also to pick up on that inappropriate route of administration. That was something that picked up through the IOLG. And we've had a couple of instances where that's happened across different departments. And previously, we probably wouldn't have picked it up as a major thing. But because it's happened a couple of times, we now have the Incident Oversight Learning Group, where all the disciplines come together. That was noted as being something that had been picked up before or happened before and was picked up and escalated appropriately, which in the past probably wouldn't have happened. But because we see all of those now, hang on a second, we're seeing a couple of those come through, and that has just helped to improve our safety record by jumping on that now, which probably would have even been noted in the past, not the way that it has. So it's really good.
Thank you. Kerry, thank you. Sorry, did you want to come back on that? Thank you.
Well articulated, thank you very much. The main item about number of incidents per 1,000 going up, the report says, or it suggests it's indicative of improved reporting. How do we know? How do we know it is indicative of something else?
So you'll notice there's a little bit of a different commentary this week. I saw the graph and thought, oh. So I looked into it a little bit more, had a good look, spoke to the team that review it, made sure that I'm looking at the categories that are being reported and there's no sort of outliers outside of expectation essentially. So what we are seeing is an improved reporting in those areas that we thought we would anyway. So those mandatory areas like falls, like pressure ulcers, we're seeing in clinical groups where we've got lower than expected numbers of reporting. So you'll be able to see from the data that's available, sometimes our children's areas, for example, wouldn't have as much reporting as we'd expect. We're focusing there. I've got colleagues that go to the areas, talk to the staff, get that real sort of qualitative information about what's happening, what aren't they reporting. So we're taking real sort of proactive action to understand about the reporting culture in those specific areas and then getting to report more if we can.
So it doesn't suggest your research and evidence indicates that it is about improved reporting.
So it is. We are trying to actively get people that are underreporting to report more. And then, like I talked about, those outliers, so the pressure ulcers and falls, we understand why. Okay, thank you.
I was just going to draw your attention. So one of the issues with PCERS being slow and the way the PCERS is done it doesn't fit very well with the coroner's approach to investigating death. So we're just about to launch, in parallel to our IOLG, a similar group to review cases that are likely to go to the coroner, where we will, in parallel to the PSERT process, use our old sort of root cause analysis methodology to look at the cases that are likely to go to the coroner, particularly the high risk ones, so we can provide the coroner with information that will satisfy him, something we will talk about Tuesday when he visits.
Is that likely to reduce, end up in duplication?
It'll have some sort of duplication, but as things stand, we've run into quite a lot of problems with the coroner because we've not satisfied with the investigations that PSERT requires. And we understand this is a national issue. It's not just our coroner, it's coroners around the country who are having the same issue.
And the right hand issue, okay. David.
Yeah, so when we go live with VPR, we would expect a lot of this. Have we thought about how we're going to filter that noise out or categorize it so it's clear what is VPR attributable and what is not?
And I'm putting in.
Yeah.
So as you know, we've developed some governance around clinical safety and clinical digital safety. What we understand already from the safety team is what our clinical groups and colleagues on the ground are expecting to hear as risks, and therefore we're able to develop our instant reporting intelligence around those risks. I think what we need to get to a point too, with your support, is understanding the immediate concerns that people have, and that they don't just find workarounds around these things, so that we're actually seeing them as instances if they have any patient safety.
I have no real evidence, but I would like to think that at least some of the increase in the reported incidents is due to the fact that we now spend a lot of time, put lots of effort into promoting the restorative culture we've now adopted. And instead of pointing fingers at people and saying, you did that wrong, we now look at what systems we can bring in to actually catch the problems. And I mean, that's been a very, very big feature of the IOLB, hasn't it? And we've worked extremely hard to promote that. I would hope that's bearing at least some fruit.
No, I agree. It's about positive learning, isn't it? Rather than pointing fingers.
Absolutely.
Trying to keep the fault more. Brilliant. Good, Andrew, thank you very much. Okay, thanks for the feedback and comments. Okay, let's move on to people and culture, and I think there's the
Yeah. So I'll be quite quick. The staff survey is on the agenda of the next item, so might talk about that then. Matthew mentioned the Ofsted inspection, but for a first inspection to achieve an outcome of good, I've lived through a lot of Ofsted inspections of education things, and that's really quite remarkable. And it would be, well, I would want to call out the hard work of Leslie and her team, ably led by Kenyon, because Leslie did an amazing job. She talked through the self-assessment with me when she said it was required improvement, and I thought it not requires improvement, but you go in saying that because that's what you feel comfortable with. And so I wasn't surprised when it came out as good, but it's a really, really good achievement. And I think importantly, it's actually positioning us really well as having a very good model for delivering learning and development, and one where we can actually now provide that for other organisations, and that can be some income coming into the organisation, which is much needed. So I think our apprenticeship programme and the way in which we are doing this is really, really good. I think the other significant update we had was on the work on violence and aggression, which is a really important piece of work, supporting staff when we get quarterly updates. I think it's the learning and improving our work as we go along is important. Actually, Matthew and I were talking about it on our board visit earlier today with staff. So I think there's work for us to do in terms of we've used the yellow and the red card process and improving reporting, and actually making sure that managers, matrons, senior staff take that responsibility for reporting incidents, even if staff feel uncomfortable about it, because it's really important that we understand where we see that violence and aggression against staff, because then we can actually do something about it. So we will continue to get updates on that, but it's a really important piece of work for us as well.
Thank you. That's really helpful. And a similar point, actually, Mike and I, we were discussing that on our visit this morning. And I think one of the things that is perhaps easy to overlook is not only sort of the incident and supporting people in the moment and trying to avoid it, it's the impact it has and how long that impact lasts on staff when they're coming back to work. But they've been really unsettled, and possibly the entire team has been. And you can have multiple people on board, members of staff who've experienced violence and aggression, and they're coming in and turning up, and then they're being extra professional. So I think something about recognising that and thinking how we support teams.
And I think there's something about staff not accepting that that's just what you have to put up with, because you can get into it. That's just what it's like, and we do need to, and we've tried really hard to make staff feel that isn't the case.
Actually, thanks very much. Leslie's last comment was exactly the comment I was going to make, because sadly in my discussions on the maternity board around abuse and violence, there's, to me, too much of a tolerance of inappropriate behaviour and acceptance by staff that because women and their families might be under pressure, it's okay for them to behave badly. So the question I was actually going to ask is what work we were doing in that area to support staff and to make it clear to them that inappropriate behaviour is simply not acceptable and that they must report. So it would be helpful to hear any comments that we have in that area.
Yes, love to. Thank you.
I think this is something that's come to light as we've been doing the deep dive into violence and aggression piece. I know when we look at the incident reports, I've been actually quite disappointed actually that when you read the narrative of, for example, racial abuse or aggressive shouting or whatever, the narrative will be very explicit about what was said and what was done. And then when it comes to the harm rating, often they've marked it as green. And that then makes it very difficult. And then when you deep dive into why it's been marked as green, it's because no physical harm. I think there's something about understanding what constitutes harm. And so there's an education piece that is underway. And we've been working really closely with Nick's predecessor and with the directors of nursing to do an education piece across the clinical groups with a view to relaunching the yellow card scheme to make it much easier and faster for people to be able to access and to use those. Because what we were finding was that people were almost reluctant to use the yellow card scheme because they're like, how can we prove that this was actually harmed? So it's something that we're really looking at, Marta, and we will be, I think, with the launching of the EPR, be in a much stronger position to be actually able to deep dive into actually where are the areas that we should be most concerned about, and how do we make sure that people are applying the yellow and the red cards whenever violence and aggression occurs.
The other bit it plays into, maybe come on to this into work. When you have got ward environments where violence and aggression is more likely, and you've got more members of staff who might have suffered it and are coming in and continuing to work, and to be operating at challenge staffing levels, the amber level rather than green, which we talked about for jolly good reason, it just adds to the pressure. So I think that's something to be conscious.
Yeah, I was going to make the point that I think a lot of the time violence and aggression occurs out of hours and at weekends as well, when there are less people around. Yeah. And I think in particular, more junior staff with less senior staff around fall victim of that kind of behaviour that we possibly wouldn't tolerate as much, in during the daytime. So I think part of what we need to do around engagement, it's not partly around what defines, violence and aggression and what does it mean to people, but also Our solution at the moment to almost all risk on the wards is a security guard, which is a sort of sticking plaster for the risk that is presented by people who are violent or aggressive. And I think we have to turn the tide a little bit on that, but at the same time, make sure that staff are safe out of hours, junior staff as well, out of hours and at weekend. So I think it's a delicate balance to be had around reporting versus de-risking the situation that people live and work in every day.
Training people to know how to intervene effectively, diffuse things. It's not an easy thing to intervene. Anyway, thank you, really helpful. And so yes, on survey.
I'm really delighted to bring our staff survey results to this board. For the first time ever, we have achieved true representation across all staffing groups, which is a real credit to not only the engagement team, but I think to everyone in the organisation who really rallied around, particularly the clinical group directors and triumvirates who were very, we unleashed their inner competitor in trying to hit the goal. And we've been able to achieve a 14% improvement in our completion rate, which I think in the current context that we're in the NHS, that speaks volumes in terms of the level of engagement that we're achieving within the organisation. And so I'm able to present this to you as I said, representing the true thoughts and experience of our staff. And so this gives added weight to the actions that we'll be taking, that we have started to take and that we'll be taking over the rest of the year as we are now in the lead up to next year's staff survey, because of the way the cycle works. What I do want to call attention to is firstly, in the spirit of celebration, we have continued to see an improvement in our people promise deliverables, and the people promise indicators are the national indicators that are used to assess how we are as an employer, as a place to work. And so we've continued to improve across all of those indicators. I'm particularly delighted that there are 2 indicators where we are at or higher than average for our benchmark group, and those are we are always learning. We've talked a little bit about how we achieve that, and that we are a team, which is really very important. I think that will sustain us and hold us as we move through into the challenges that we know we're going to be facing in this financial year. Where I'm worried is around, we've got 3 key areas that we're focusing on. Burnout. So we've seen increased reporting of staff saying that they are experiencing either the symptoms of burnout or that they're coming into work when they're feeling unwell. And I know later on in the agenda, I'm going to celebrate the fact that we haven't seen an increase in our sickness absence rates. And so there's something about how we triangulate some of this data. And it may be that part of the work we need to be doing, and we're looking at what we can do to improve work-life balance, help our staff to manage stress more appropriately. And there's also something there around physical well-being, because that plays into that sense of resilience and ability to recover. The second area we've already started to talk about, which is violence and aggression from the public. And I've talked a little bit about the work that we're doing to enhance the yellow and red cards and how people access that. Thinking particularly around how we support people to de-escalate situations and to manage conflict in a way that will support them. And also the breakaway training. I have to say that I've actually completed the de-escalation and breakaway training myself, and it was excellent. And so we'll be continuing to roll that out. And during that training, I was actually there with members of a single ED team who were doing the training together, so that they can support and amplify the impact of the training together. And the final is around discrimination at work. And this is considering the demographics within our trust, where over 50% of our staff are Black, Asian and minoritized ethnic backgrounds. We look at who is actually delivering the care, but then we're also aware that we do see less representation the more senior you get within the organisation. This is particularly concerning. We see that we are the worst in our benchmark group for staff reporting discrimination or harassment from their line managers, colleagues or team members. And that the highest reason for that, so in the survey, we're able to triangulate now the data by your response, but also by other characteristics. We see that the reason people have cited for that is the highest reporting reason is but we also see that people who told us they had a disability are also reporting that they are experiencing increased levels of discrimination. So we're in the process at the moment of trying to understand what is driving that. Because when you look at our RES data, when you look at our ER cases, I'm not sure that that is flowing through into other sources of information. So we need to understand, have more conversations with our staff, more listening events with our staff to understand what's driving that. In terms of how we're working to combat discrimination, there's encouraging people to speak up, and this is where the People Speak Up service is going to be vital in driving that up. Continuing to encourage our staff to engage with our staff networks. Again, in your intro, you talked about the meeting with the networks, but again, going along to those meetings, I'm not sure we're seeing the level of engagement that I would hope with some of those networks. So what more could we be doing to encourage that? And continuing with the training we provide to our colleagues, including continuing our commitment to the active bystander training. I think that's going to be a key way for us to address this. If you see someone being discriminated against, you don't support them after the fact. It's actually, let's tackle it in real time.
Thank you. Thank you very much for sharing this data, and well done. I know from bitter experience how challenging it is to get numbers up like that. I think you raised really useful points about discrimination, because sometimes what you see and what's the data, they don't always match. So I'm welcome to hear more about that when the information's there. Are you able to have some more frequent pulse surveys over the next few months that you can report back on? I was particularly interested because looking at discrimination, burnout, risk areas when you're undergoing, restructures and organisation change. So if you could report back on that, that would be great.
So we are planning to introduce the pulse surveys because there's now national support for that. So that's brilliant.
Yeah, just to echo that it is incredibly positive, and I think the significant improvement in actually learning, but particularly working as a team, being part of the team, I think it's really heartening, because that's an awful lot of what the executive, Matthew and colleagues have been trying to do, is to really get people feel as though they're part of this BHR team. So to see that improve so significantly, and for us to be above average, and we used to aspire to be average, so to actually be above average is brilliant and really, really good. I just think that it's sort of just continuing Caroline's point a little bit, with the change that we're going to be going through and with the savings that we're going to have to make. I think it's really important that we actually still continue to have the emphasis and do work on things around burnout and violence and aggression and discrimination. And as a board, we just need to be satisfying ourselves that in everything that is changing and things that we're cutting, that we're not actually making that situation worse. The pulse surveys will help, but I think it's just something that we need to keep an eye on, as there's going to be a lot of change and a lot of cuts. And we don't want to be cutting things that actually are helping our staff. It's, I know that people like Simon and Mike have been working really hard on social value to make sure that we're actually able to get sponsorship from people so that we can continue to do some of the things that our staff have really valued, the summer events and the marquee and things like that. But we shouldn't chuck the baby out with the bathwater on those things.
So it's a really good set of results. I think there's a couple of things. The pulse surveys will be useful. My experience in previous organisations is the more you survey people, the less they respond after a period of time. So pulse surveys will help us get into the detail. They might also dampen the response to the National Staff Survey. We did a lot of this in Oxley's, and one of the survey response rates started to come back with, please can you stop surveying this? So you have to use these things quite judiciously and quite a focused way. One of the areas we need to focus on is the reports of discrimination. Because we certainly know that we've got an issue with discrimination between white staff and non-white staff. We're also increasingly getting reports of racial discrimination between different non-white staffing groups as well. And Janine's team are doing some work on that to understand where we've got tensions within that, because we've got some particular challenges within this organisation, because we're an incredibly diverse organisation. I think we need to be careful to just make sure we don't assume that when we talk about racial discrimination, it's not white and non-white staff. There's multiple dimensions to that reflects the richness of the ethnicity and the heritage we have within this organisation as part of one.
I'd also like to add congratulations on the results, having achieved so many, and there's a lot of positives in there. I agree, you highlighted the key areas of challenge. I was delighted to see the team one. I've really noticed in coming in new to the organisation and going around and visiting, it's one of the things I've commented on. I've really felt that sense of team within teams. And I think that's a real strength. And I think it's something then to build on, because if we highlight that people are noticing that and it's a good thing, and we can perhaps build on it in terms of then how do we teach teams to have those difficult conversations? How do we teach them to talk about the stuff that's bothering people, or is it working for them, or is challenging, whatever it is. But building on the strength of the fact that there is a team connection is possibly a route to handling some of the challenges. Brilliant, thank you. Good stuff. Right. Here we go. So, finance and operation performance. So, first of all, the finance investment is complete.
Thank you very much, Chair. We had a meeting yesterday as well, so the March meeting sort of segues into the April meeting, so I'll just talk about the April meeting and give an update on that. Ended the year £1 million better than the forecast of the £32 million deficit. Attributed to government savings targets and significantly increased activity level, reducing bank and agency spend. And we recruited another 500 permanent members staff as well. And we're really focused on that. So we now have in place a trial tracker which tracks agency and bank staff spend on a daily basis with focused efforts and target those efforts in areas where there's opportunities to reduce them and those. On the IPR, so today, whilst Matthew was making his report, a news flash up on my phone from the BBC. It said that it is the warmest day on record for May ever. It's a bit like what Matthew says. Every month is the busiest month for this hospital trust. And the only way we're going to solve our activity levels is the same way we're going to solve climate change. It's about systemic change and behaviour change. It's not sustainable for any organisation to get busier and busier this year with having more resources, but not enough, not managing the activity from the front door. So pleased to say that we are the best in London for RTT. However, we really do need to think about long-term sustainable change. And in terms of savings across the piece, we yesterday endorsed for the board to agree North East London Health and Care Procurement Partnership, which will deliver significant savings across the piece with our health partners. Also, we endorsed the King George Hospital FM delivery model, and again, it will improve services and make savings as well. And we saw the benefits of insourcing gynae on health inequalities, on the patient waiting list, and there's a number of other improvements that were shared at the board, at the committee yesterday, and received an update on digital and the EPR, which I know that we're all keen on, and its implementation date of 1st of September. It's something that is laser-like, flawless, focus on that? Have I got my objectives right there?
It's the 13th of September, but yes, we are absolutely focused on delivering to that. Yeah.
And that's all I want to say, Charles, and because I don't want to say thunder from Mike, David and Bjorn.
With that, shall we, unless there are any questions, move on to you, Fiona?
Thank you very much. And as Mahbub said, we reviewed the entire integrated performance report yesterday at the Finance and Performance Committee. I won't do a read through on the report, but I will highlight some of the areas that I think are relevant to us in terms of risk, but also some of the performance areas that we need to focus on in terms of improvement. So I've taken away all the achievements we've had over this year, and I'm very proud of the teams who delivered that. Interestingly, just to sort of correlate the conversations today, we've talked about busy, we've talked about burnout, we've talked about violence and aggression. And our UEC programme, particularly both EDs, are an area of concentration of all of those three factors of risks. And so, it's a complex job to try and improve the performance of a department that has, quite a lot of risk in it. And it's the default open door for the community, place of safety for the community, and it's the only place that's available to patients 24 hours a day. So I'll just say that because the focus of our activities going forward will be our ED performance, which is tracking really low compared to the rest of London. And in the graphs, that's under type 1. That's our own ED performance. That's not patients in the UTC, and it's not patients in specialty ED assessment units. So we know that patients still spend far too long in our emergency departments. We discussed a range of interventions like rebuilding at Queen's and other areas of improvement like same-day emergency care. But nonetheless, we recognise that corridor care and time in ED is still a factor, and I think sort of incumbent on me to call that out, but also incumbent on me to kind of get underneath some of that in the year coming and really try and move that along in terms of waiting time. We've made a small change to the mental health slide on slide 6 because it is a topic of regular conversation, but also we really do need to get under the real root causes of this. So we know that mental health presentations in ED are too high. We know that disproportionately our hospital sites receive more mental health presentations than the mental health providers in our area. And we, to a certain extent, understand some of the reasons for that. We think the challenge is now, and so what are we collectively doing about that? I think that we have a role to play in fixing some of that, but it will truly be an integrated approach, and it will be a partnership approach. And I think at the moment, I don't see a huge amount of evidence that we're moving some of that on. Knowing that patients spend as long as they do, well over 12 hours in our department waiting for a mental health intervention or to be discharged or taken to a ward area for mental health admissions is subject to much discussion, and I think that we need to ramp up going forward with our partners around doing something about that. Across both hospital sites, we've seen an increase in length of stay. That is a direct contributor to length of time in ED. We call it flow generally, but what it really means is that if you're in ED and you need an inpatient bed and our inpatient beds are full because our length of stay has gone up, then that is a problem, and we do need to fix that. By contrast, we've got much better at coping with and managing and negotiating complex discharge. So, 2 years ago, I would have said to you that there are many patients in our beds that don't need to be there. There are complex reasons for that, but they are multi-agency, and we're working with agencies to fix that. I think what we've shown is that the multi-agency work has really borne fruit, and our what are called criteria to reside as low as they've ever been, really. So it would be easy to say it's all about complex discharges. It's much more difficult to say it's about short length of stay getting 1 or 2 days longer, but I think we should call that out as something that we have direct control over and do need to address. In planned care, Mahbub has already mentioned that our achievement as a high-performing acute trust in London for RTT, we've systematically been the best acute trust in London around that. And the graph is a delight, if I may say, to show that really hard work, determination and attention to detail in planned care really does deliver rewards. And so that's a sustained delivery. It's you can see the graph well past the statistically relevant parameters, and we may have to change the graph going forward to make the one of the axes is slightly different. So, but good news there, and well done to all of the teams. Interestingly, also our commitment to reducing the length of time patients wait on the next graph shows again sustained delivery, sustained improvement, and actually 50% of the residual 52-week waiters are in gynae, which we know and have discussed in detail in other forums. So lots more to do, continued support and oversight in that area, but very, very encouraging direction of travel, and we'll continue all of our work to make sure that we address that permanently and we don't return to really long waiting times in the future. Our health and equality slide particularly focuses on the planned care patients and shows quite clearly that there is a disproportionately long wait for women compared to men, which would correlate with our gynae PTL and the performance I just mentioned, and that within all of our long waiters, we keep an active track on which groups, which cohorts, who those patients are, and whether there are other interventions we need to think about to reduce any inequality in that space. And equally, as we mentioned at the beginning of our meeting, our learning disability patients are right in there in terms of proactive care and design. So we really do know that our learning disability patients have huge amount of support, proactive care and design around their pathways to make sure that they don't trip into long waitings, which has been something that's happened in the past. And DMO1 is compliant and has been now for a long time. I think Matthew mentioned that in his chief exec's report. Again, we've got theatre utilisation and in-session efficiency, which, if I may, Mike and I will delve much more into around our productivity and efficiency board seminar going forward. But again, the NHS operating plan this year focuses very much on utilising underproductive and less efficient capacity to deliver change. So we will be doing that. And the final slide is cancer, which is very encouragingly very green. There are some red areas around first appointment for 2-week waits, but they're all well within the 14 days. And we continue to manage each tumour group specifically with oversight and tracking with the clinical groups. So lots of work going on there to maintain the position, and equally a direct focus on the backlog, which is anyone over 62 days on the PTL. And a lot of tidying up to be done around coordination of complex investigations, but that work continues. Thank you.
Thank you. There's one thing that jumps out when we talk about the length of stay, and that being something particularly within our own area of control. It's obviously clinical decision making as to when to discharge. So is there a sense, do we understand why that might be drifting if it's not because we can't move people on? And is it linked in any way to talk about risk previously and so on? So I just wonder what's causing an easy length of stay if it's within our own control.
So one thing I've seen happen in previous roles is when you more services like STEC, you take out some of the shortest length of stay patients, and some of our length of stay figures are artificially brought down just because we've admitted more people who we're now seeing treated and discharged from the STEC. So if you take out a bunch of short stay patients, you actually increase your length of stay, but it means you've got more appropriate patients in the bed base. So I'm not done the work here on that, but certainly at Princess Royal, when we opened some short stay facilities within acute medicine, our length of stay suffered as a consequence.
So it'd be helpful to check that, because if that's the case, that we're actually, by doing better at the short end, we're altering the average.
Yeah.
The narrative might helpfully explain that rather than give the wrong impression if that's the case.
Yes, and
Fiona might not agree with me on that as well. So.
there's everything we measure there's a complexity to it, because we constantly improving. Overview services, we probably admit less inappropriate admissions now, so our admissions are truer than they were 3 years ago. And also we've taken away the bed blocking. So we've taken the whole cohort of people who just stayed there for a long time. So we've almost given ourselves more capacity. I will address all of that, I think, numerically and statistically, because we've got in the productivity assessment that Mike and I will do. So we can see some of the nuances around the change in denominator. So admission numbers, discharges is the way of proving us right or wrong in that regard.
We know that when we opened our first aesthetic, the Benco, we did some work that showed that our 0 to 72 hour admissions dropped. So we admitted fewer short stay patients as a consequence of being turned around through aesthetic.
Yeah.
The consequence of that is that your average length of stay, and that's why you have to look into your median and your mean. As you get some of your very long tail patients as well. But so Fiona's arguing for size rather than mileage.
We're double, we're always a double act.
Brilliant. Thank you. Oh, good, but it's always good to see things that are going positive. Being best in London at stuff with everybody. Okay, finance.
Thanks, Sarah. So I think the board gave the key update, which was we ended the year with a 31 million deficit. And I can remember we had forecast at 32, so we're coming just underneath where we needed to, which is great. The draft accounts have been submitted. They went in on the 25th of April, and we've now got auditors starting working with us again, having only just left, but they're working with us again now. And hopefully they'll be with us until the 30th of June this year, when the national deadline is for submission of the accounts. The key reasons for being off plan, 13 million shortfall on the savings, it links to the issues that we've heard about. The mental health, we continue to spend about 6 million. We hope the pathways would have improved in the year and that spend dropped, but we haven't seen that yet. And then the general busyness, which means we're still spending, corridor care, for example. Some of our CDC income was lower than we'd hoped or planned for, partly due to delays in opening. All things that we're planning for improvements on in the next year. I think we should say, it's been mentioned, but the report does include significant improvement in agency spend. We have hit the agency cap, barring a few tens of thousands, which in my mind gets rounded away. So we've hit the cap. In the second half of the year, actually, we have an exit run rate closer to 15 million. So we really have done well, because we know we had a slower start in the beginning of the year. We've included a slide on bank run rates. What we can see is a reduction of 3 million, but we know our substantive pay has gone up as we talked about the successful recruitment into the union. In terms of capital, we spent all of the capital that was available to us, about 23 million. In the report, it looks like we've underspent. Now, remember when we sorted out the accounting for the EPR when there was a prior year adjustment, there's a technical kind of almost £3 million worth of reversing thing that happened in prior year, which is why that looks as it does, but we spent the full £23 million. And then the other thing is on cash. So we've been worried about cash balances throughout the year. You can see where we ended up just north of 20 million, and that really correlates to the receipt of £21 million worth of cost pressure funding that came through from National in month 11, I think it was. And we've been fully paid for the accrued ERF and CDC funding that we were concerned about delaying timing for. But without that 21 million, you can see we would have had an incredibly low cash balance. So that does remain a real high area of concern for me as we go forward. But they're the key messages.
It's impressive in you to deliver an outturn that's slightly better even than was expected. And just to note the number of cost savings that were recurrent. So that's shown that, proper change in the way we're operating rather than just short-term savings, which is supports efficiency and so on. So that's really good to see. Doesn't detract from the challenge games, of course. We're here for you.
We're investing in psychological services, yes.
We'll just watch. Brilliant. Thank you very much. Any questions, any other comments? Brilliant. Okay, and me?
Yeah, so not wanting to labour too much more the temporary staffing point, but I do want to call out just a couple of things. So jumping back a bit into Mike's report, I do want to highlight that our bank spend, even though we haven't fallen by as much as we would hope to see we've fallen at this time next year, relative to the previous year, we can see that we haven't had the same level of spike that we'd expected as people took their annual leave. And the further picture I want to add to that is, as you know, we've been really on it in terms of encouraging people to take their annual leave, so we're not carrying in a huge cost into this new financial year. And I would say that's largely been successful. I think we've seen only just a very small number of exceptions in line with our responsibilities as an employer, either through reasonable adjustments or people off sick, but really clear and very strong compliance. That's good news. And on that same point, also noting the 50% decline that we've seen over the financial year in our agency spend. So last March, we were at 319 agency WTE, and this March we ended at 154. So, and we have a clear plan to continue to drive forward in that to get us to our 1% agency target. So that's good news. The other things I do want to highlight here, recognising the challenge that we had in getting the momentum that we were looking for in terms of the premium and medical spend. I know that there is a plan underway and we are seeing that momentum build. So some of our more expensive doctors have now left the building. So when we look at, again, the numbers, hopefully that come to the next board, we will see that start to play through into our month one position. Not promising anything. I could see you frown a little bit there, Mike. So don't want to be too early with the spoilers there. And part of how we're achieving that is, as we've already talked about, in terms of our substantive recruitment. Whilst we do have rigorous controls in place around vacancies and the triple lock approval process, where we do need to recruit and where there's a very clear line through to removing temporary staff, we're able to move forward with that. And my teams are reporting that it's much easier to find candidates who are willing and interested in coming to work for us, good people. I've been on a few consultant panels over the last few weeks, and the representatives from the Royal Colleges have often said, if you don't take them, I will. So that just shows the calibre of the people that we're now attracting, which is good news. And in terms of the Band 5 nursing recruitment, I'm really pleased to say that we remain on track and yet again not have to go overseas to recruit. We actually probably have more trainees coming through than we have vacancies, so the team are working really closely to manage how we go about slotting people into those posts. On the point about sickness, our sickness trend again continues to move in the right direction. We haven't seen the spikes that we might have seen previously. I'm concerned, though, that the main reason that we're seeing people being off sick is anxiety and stress. So that burnout metric is starting to play through into what people are telling us. So we'll continue to monitor that really closely. That being said, in terms of our employee relations activity, the main cases that we are managing are around absence management. I think it's really important that we balance that duty of care with actually let's manage people through our processes as well. So we support people back into work. I know that aligns with national objectives as well. And I'll stop there. Thank you.
And that one really stood out to me. So does that mean people are just not turning up for work, or they're always late? That absence, disciplinary stuff. What is the issue?
So we have certain thresholds that people will hit. So worst case, you might have someone who just turns up, who just calls in sick every Monday, and that will trigger. You may have other people who've been off sick for a very long time, and who therefore hit our thresholds for us to be thinking about, okay, are you well enough to come back into this job? Do we need to be referring you through occupational health for redeployment somewhere else? Or yeah, so it's really actively managing that. So previously, we perhaps weren't as strong on that, and that would lead to us incurring backfill costs for longer than we would otherwise hope to.
So it's actively dealing with persistent, larger, significant issues.
Yeah.
So Caroline, Ruth.
I think it's amazing achievement about the sickness, particularly given that absence management is often in the too difficult to deal with bucket. And you're never going to get awards, for managing out of the room. It represents a significant expenditure. But to have the sickness numbers at the time of reducing bank. I was here at some very difficult times where people were doing bank shifts and calling in sick. We've moved a long way. Amongst the people who regularly did bank shifts, what's the plan for any complaints or people might say that it's become customer practice, they deserve compensation, things like that. What's the trust position regarding that reduction or removal in income to person?
So we are very concerned about that, and it's one of the so in terms of the safeguards we put in place. Firstly, we want to ensure equity of access to bank shifts where they are available. So there'll be less of them. So it's really important we make sure that people aren't holding them to themselves. And so in terms of our regular reporting, so I have a weekly workforce call. On that call, I'm asking for who is doing the bank shifts that we are releasing. So there is that. In terms of people claiming customer practice, I'm not aware of that being flagged as an issue. Because again, I think in terms of the contractual arrangements that we've had, I'm not sure we've got anyone who will have been doing a bank shift every whatever day for years and years to be able to claim that. But that's a really good point to raise, and I'll be sure.
I think we'll be prepared for it.
Kerry was just going to come in.
I think just for your information, the communication of this change was well made and was done well ahead of time. So I think that, especially from the nursing side, the deputy chief nurses and Catherine, made sure there was really wide communication. If this is going to happen, this was the day any bank shifts that were honoured, and there was really good understanding of how that's going to happen. So I think to me, it was really clear that to make it really well known that there wasn't going to be not an immediate financial impact to people not booking bank. And as I say, although there will be less bank shifts available, we know that as the substantive workforce has increased, especially in the nursing line. So there are, I'm hoping, more people employed in more substantive.
And then
my comment was more about around fitness, and I think it could be things that maybe start to come, or this might be an unpopular thing to say, but I think we saw it post-COVID, where there was this kind of rhetoric of COVID was awful, it was really stressful, I feel really burnt out. And I think some people, that absolutely happened at times in COVID. But I think there was also times post-COVID where those levels of stress weren't there, but people kept saying it. I think we've got to be careful as a trust that, yes, we need to train people about resilience and how to manage that stress and anxiety, but without also almost reinforcing that is there and that this is burnout, when actually, is this just your normal job? And that you should be able to cope with it, which I know sounds really cruel and mean, but I think people do kind of pick up a feeling and then they feel justified to calling in sick, when actually, is it a job problem or is it an employee problem? And they are very different. It's a hard line to tread, so I'm glad I'm not doing it. But I think in different departments, we've got to be really clear that we still expect you to do your job. If you're going above and beyond that, and there's a reason for burnout, we want to know why that is as well, so we can tackle it.
I think that's a really good point, because I'm conscious that even as I was talking about burnout, we've been talking about Amber being the trigger for bank, or the level that we started for bank. That's still going to be red, because we've grown our substantive workforce such that if everybody who's due to be on a shift turns up, it'll be a blue shift. Yeah. And so there's something about the language that we're using here that, yes, there'll be less bank shifts, partly because we've got more people
Yes. Peter.
I just wanted to reinforce Janine's point about the improved caliber of consultant candidates we'll see any of us around this table. I mean, it is really striking. And as the new longest serving member of the exec,
Do you get a special seat like Parliament?
someone has suggested I should ask for a larger office. That was not always the case. I mean, for many years, we will have, those of us who've been here for a period of time will have sat on panels where the caliber has been not that. So I think it's another indicator Matthew was alluding to of improvements and that we are now a more attractive.
Which is brilliant, and these things just build, don't they? So that's really excellent decision. Right, we're really running tight on time. We've got one more item of substantive, which is the audit committee.
Save the best till last.
Exactly.
Exactly. Okay, we've met twice since the last board, primarily because of the need to conclude our annual reports and accounts, which the board will know we signed off in early April to our great delight with a clean audit report. So fantastic, absolutely fantastic. We did amend the annual report and accounts with minor changes as required by the auditors around clarification, but also to reflect the point, Ron, that you made about patient participation. So we added that in, having missed it the first time round. So Mike's already said the auditors are back. I think they took a day off and then they came back in to start again. They have actually already completed their interim, which they completed sort of February time, didn't they? But now we're into the throes of the final audit, which of course is going to be clean and smooth and entirely straightforward and will land on time, won't it? Brilliant. Of course it will. Other things to report, internal audit are really on a glide path now to producing their head of internal audit opinion, which we will receive in May. They have a few reports out in draft that we will also see in May. The data security protection toolkit usually runs last, but we're expecting to see that. And ditto counter fraud are doing their end of year activities as functional, etc. And just for the board to note, these will be the last reports from our incumbent internal auditors and counter fraud specialists. We went to market and a new organisation will start once these final reports have been received. We had a report on an update on how we're doing with the new declaration of interests system. There's been a huge push around communication on this, and the data that you see in the report is really an extraordinary improvement from when we reported last time, and is notably better than what we have seen in previous years. So the system is working, but we are not close enough to the 90s, so that press and push continues. But I really think this is the way forward, and it's a good system once we've ironed out the wrinkles when the year changed. Oh, let's do it again. We didn't understand. So we nailed that, I think. So really good work there. We're continuing to push forward on the risk register. We still have Brown working with us on that. Each iteration of the report improves, but I think it's fair to say we've still got quite a lot of poorly articulated risks stroke issues that are quite difficult to work through, and therefore there is a bit of a focus on aligning all of that and making it much stronger. We had a workshop around our language for risk and our risk appetite, and that obviously will inform future iterations of this work. I don't know, Linda, if I've covered everything, but if not, I'm sure you'll add anything for me. Last thing I'm going to say is there's been a new international financial reporting standard about insurance contracts. You might think to yourself, why does that apply to us? But we are required to check whether it does or whether it doesn't. And Alex did an extraordinarily robust piece of work to prove that it doesn't. So we were right all along. There was nothing for me to escalate. The trust seal will come here next as standard. Before we go to that, any questions that anyone would like to ask?
Sue?
Oh, right, no, okay, so trustee, so the audit committee received the trustee report, it's been used 6 times since the previous report. They were all on building contracts and a couple of leases in relation to buildings, so that's just here for the board to ratify.
Lovely. And are we happy to do that? Brilliant, thank you. Okay, just about getting there, we've running out of time, but we've got a couple more items. So anyone needs to raise anything under A or B? Yep. If there is any particular feedback on meeting effectiveness, shout now or message me afterwards if it's something that you wish to share. And then just finally, questions from the public.
Yes, Chair, if I may ask two, perhaps it's easier if I just give you both questions at the same time, if that's okay?
Yep.
The first is assurance there will be some form of consultation about any service cuts. So if I got it right, there might be something happening about vitamin D screening. I wasn't quite sure if I got the right end of the stick there, for example. And secondly, I take on board the point, the ever increasing numbers that are coming in. I put up on Twitter how accurate research is, but if you wait more than 12 hours, there's a significantly higher risk of death. It looks as though it's well over 100,000 such people coming into PHIUT each year. And what's the plan for all the development going up? Is there are memos and papers going on to the Department of Health saying we need more staff to cope with the growing population?
Thank you. Right. So something high on this. And so in terms of if we ever got to the territory of talking about withdrawing services, we definitely consult on that. So there's nothing on the table at the minute that will take us into that territory. Some of the areas I talked about, so for example, the vitamin D test, they've got very limited clinical value. In a number of areas, what we've seen is that in recent years, the availability of tests means people are just doing more and more testing. There's some really interesting data coming back from South East London. People might remember they had a big cyber attack and they hugely reduced the number of blood tests that was just affected. They massively reduced, for example, the number of blood tests they carried out in the hospitals. It's had no negative effect on patient care, and it's actually reduced their costs considerably. So this is about us following national guidance and not spending money on tests that don't have clinical value. But certainly if we get to any territory around service cuts, there would of course be a consultation with affected members of the public. What I'm hoping is that focus that we've talked about on temporary staffing and on things like procurement, pharmacy, etc., avoid us into that territory. And as I hope you can hear, we're really proud of some of the stuff we're managing to do at the minute. We're keen to do more. Our hospitals are getting busier, but we're doing some great work. In terms of the growing population, it is very much in all of our minds in North East London. I think whether it's BHIT, whether it's places like Whipps Cross and others, are seeing significant numbers of new people moving into the area. There's partly a responsibility through local authority conversations to make sure that there's investment in infrastructure around that. We do talk to our local authority partners around that, but it does definitely create pressure on us. I think lots of the pressure is demand, not necessarily for acute hospital inpatient services. What we can see in the 3 shifts that they're talking about in the plan, from hospital to community, treatment to prevention, I think what we'd like to see is, more investment in primary care, more investment in community services, and certainly a longer term focus on public health. Healthier girls can grow up into healthier adults. And I think these are the kind of directions we need to go in, rather than just building bigger and bigger hospitals for the sick. Thank you for your questions. Cheers.
Thank you very much. Okay, I think that brings us to the end of our public meeting. The next meeting is scheduled for 3rd of July, and that will be at Queen's Hospital, and usual start time of 12. So thank you very much, and thank you for attending, and thank you for those online who've been attending. Thank you very much.